Good afternoon, dear colleagues. Welcome to our webinar on transgender, ethical challenges and mental health. My name is Meryam Schouler-Ocak. I'm Professor of Intercultural Psychiatry at Charité Universitätsmedizin Berlin in Germany. I'm the chair of the Committee on Ethical Issues of the European Psychiatric Association and board member of the European Psychiatric Association. This webinar has been prepared and organized by the Ethical Committee of the EPA. I'm very happy that you attend this webinar, which is dealing with a very hot topic. We could win really very distinguished, recognized experts in this field with whom you can discuss this topic later on during the discussion part. The legitimation of transgender identity has become a widely spread phenomenon in many societies across the world. Contingently, too, is a social aspect. It is promoted by various social groups in the name of the individual's rights. While physicians from various disciplines are very involved in the medical transformation process, they have scarce information about the psychological outcomes. In such a context, what is the psychiatrist's role in the medical committee and what are the biomedical ethical guidelines? In this webinar, we will discuss ethical boundaries in children and adolescents and ensuring transgender youth receive the care they need. As mentioned before, we are very pleased to have found recognized as experts in this field. We have received many questions before the webinar. Please use the chat button for your questions, remarks, or comments if you have some. First of all, we will listen to both speakers, and then we'll go on with the discussion part. The webinar is going to be recorded, and you have the possibility to watch it or see it in our website, the website of the Committee of Ethical Issues of EPA. I'm very, very happy now to introduce our first speaker. It is Professor Tyano. Sam was born in Israel and graduated at the Medicine University of Strasbourg in France. He came back to Israel and opened the first closed adolescence department at the GEHA Psychiatric Hospital affiliated with the School of Medicine from the Tel Aviv University. Later on, he was nominated director of the same hospital and did it for 20 years. He came back to France to complete his fellowship in child psychiatry as well as as a visiting professor at Yale University. He has been elected president of the Medical Scientific Council and created the first board examinations for certifications in all medical disciplines. Later on, he chaired the first National Advisory Board for Mental Health and was elected president of the Israeli Psychiatric Association and president of the Israeli Child and Adolescent Psychiatric Association. Nowadays, he is the honorary president of both associations. Dr. Honoris Causa at the Bechterew Psychoneurological Research Institute in St. Petersburg. He also served as a member of the Executive Committee of the World Psychiatric Association and chaired its Committee on Ethics and Review. He is currently a member of our Committee on Ethical Issues of the European Psychiatric Association. I'm very, very happy that Sam has agreed to present the topic on ethical boundaries in child and adolescence. So Sam, the floor is yours.
Thank you very much.
Do you need any technical assistance?
Thank you. Do you see my slide?
Yes, we can see them.
Okay, good. So, thank you for a very kind introduction. And the title of my presentation today is Ethical Dilemmas related transsexualism in childhood and adolescence. I have nothing to disclose. We will start with an update on the current understanding and practices around transsexualism. In many transgender clinics, the child and adolescent psychiatrist is part of the multidisciplinary team with a role to assess the child or adolescent's mental status, strengths, and weaknesses. We will discuss the ethical dilemmas that are intrinsic to this role while taking into consideration the pros and the cons of the medical and surgical interventions. Finally, we will suggest for EPA to take a proactive standpoint and to develop a position paper specifically aimed at helping the clinicians to deal with transsexual patients who ask for assessment or counseling. Coming to the definitions, the term transgender refers to people who experience gender incongruence, which is defined as a marked mismatch between one's gender and the sex assigned at birth. Concerning the classification, the ICD-11 redefined gender identity-related health, replacing transsexualism and gender identity disorder of children with gender incongruence of adolescence and adulthood and gender incongruence of childhood, respectively. This reflects current knowledge that gender diverse identities are not conditions of mental ill health and that classifying them as such can cause stigma. The DSM-5 uses the term of gender dysphoria to classify people experience clinically significant distress resulting from gender incongruence. Are we in an era of trans epidemic? Services for children and young people have experienced a significant rise in the referrals worldwide. In the UK, the National Service reported 382% increase in 2018 and 2019. In 2003, the Royal Children's Hospital in Melbourne diagnosed just one case of gender dysphoria. Today, there are 200. The mean numbers reported in large sample studies from New Zealand and US are around 1.2% among adolescents. Time trends in relation to the profile of children and young people referred to services have also been noted. There has been a shift in recent years to an increase in referrals of assigned female at birth, in contrast with assigned male at birth. The numbers concerning the frequency of trans in variable from country to country, and sometimes different in same country, depending on the nature of the studied sample, general population versus specialized clinics. We have no good explanation for the phenomenon. For instance, is there a biological component in this increasing prevalence of transsexualism, such as changes in the intrauterine hormonal exposure? On the psychological level, has Freud's sexual theory become irrelevant? Is transsexualism a real new phenomenon? Harry Benjamin already described it in 1953. Lucien Israel and Pierre Geisman explanation in 1960 already that people asking for changing their gender are actually homosexual individuals who cannot stand their guilt feelings. Are these theories be irrelevant today? Or is it the society that have changed its religious values, morals, and norms about sexuality? From the practical standpoint, there are two main approaches: the affirming approach versus the watchful waiting approach. The affirmative approach endorses the child or adolescent belief that they were born in the wrong body and requires from the clinician and the parents to support the child's self-identification. The watchful waiting approach emphasizes the risk of sending the child or adolescent down an irreversible path from which he or she cannot desist. I would like to mention also that childhood onset transsexualism needs to be differentiated from adolescence onset transsexualism. Child onset and adolescent onset trans constitute different population groups with different developmental trajectories. For instance, it seems that children with trans have more chances to desist than adolescents. The degree of persistence of the gender dysphoria from childhood to adolescence vary from 2.2% to 30% in males and from 12 to 50% in females. The intensity of gender dysphoria in childhood seems to be a predictor of continuing trans care in adolescence. Stinsma in 2011 reported that the time span between 10 and 13 years is determining. This difference has significant clinical implication. I propose that the watchful waiting approach may be more appropriate for children and the affirming approach more for adolescents. Concerning the medical statement, for gender incongruence in trans healthy typically occurs in 3 stages, beginning in early puberty. The stage 1, puberty suppression with puberty blockers. The stage 2, gender-affirming hormones. And stage 3, surgical gender-affirming interventions. Monitoring clinical pubertal development every 3 to 6 months and laboratory parameters every 6 to 12 months during sex hormone treatment has been recommended by the US Endocrine Society in 2020. Child and parents' consent is required before each one of the 3 stages, of course. On the psychiatric level, the goal of the pre-transition psychiatric evaluation is to evaluate the level of maturity and the understanding of the potential consequences of the medical and surgical treatments. The existence of eventual psychopathology, like psychosis, autism, personality disorders, body dysmorphic disorders. The assessment includes a clinical interview, including projective tools such as the house person tree drawings for children, and questionnaires like the CBCL, Youth Self-Competency Rating, Social Responsiveness Scale, and MacArthur Competence Assessment Tool, and an interview with the parents. When we do this assessment, we need to keep to mind the data that exists about the psychiatric comorbidity before transition. Very important point for us as practitioners. The research done by the Canadian Trans Youth Health in 2017 described their key findings on 900 transgender youth from across Canada. though not explicitly said in the paper. It seems the sample was composed of youth who have not gone through sex reassignment process. Nearly 2/3 of youth reported self-harm within the past year. More than 1 in 3 had attempted suicide. Rates of self-harm and suicide were lower in the 19 to 25 age group than the 14 to 18 age groups. 70% reported sexual harassment. 36% of the younger participants have been physically threatened or injured like last year. And 30%, dynamically speaking, did not have an adult in the family they could talk to about problems. Similarly, in the US, 15% of transgender students reported a suicide attempt requiring medical treatment in the last 12 months, compared to 3% of all students. Also, Danny Robert Dufour in 2021 reported a study in Vancouver that found a rate of attempted suicide as 5 times higher than in general population. And more, Belgian study published by Van Kovenberg in 2021, reporting on a follow-up from 2007 to 2016 among 177 adolescents who consulted the Seoul Belgian Pediatric Clinic, reported on 40% of suicidal thoughts, 32% self-harm behavior, and a rate of 2.8% of committed suicide. The prevalence of suicide attempts among responders to the National Transgender Discrimination Survey is 41%, which vastly extended the 4.6% of the overall US population who report a lifetime suicide attempt, and is also higher than the 10 to 20% of lesbian, gay, bisexual adults who report ever attempting suicide. According to the Health Behavior of School-Age Children study, 13% of the boys and 22% of the girls between 13 and 18 years old had suicide thoughts on multiple occasions. In 2018, this study also reports that 8% of the boys and 20% of the girls between 13 and 18 years old have ever intentionally harmed themselves. In their sample, the numbers were higher. It turns out there is a significant post-transition psychiatric morbidity also, though outcome data are still scant. One may wonder why. A Swedish study of 324 individuals who had undergone genital surgery between 1973 and 2003 found much higher annual suicide rates, 43 times the rate for matched female controls and 16 times for male controls. Their conclusion was that sex reassignment, though elevating gender dysphoria, may not be enough as treatment for transsexualism, psychiatric morbidity, and there is a need to improve psychiatric and somatic care after sex reassignment. Before I address the ethical issue, that emerge from this bulk of data. Let me add a note about conversion therapies. Over the 20th century, talking therapies and medical treatments emerged that tried to make homosexual or bisexual people heterosexual. These so-called conversion therapies have no scientific basis and have been shown to be harmful in this context. In many countries around the world, conversion psychotherapies may include barriers to gender-affirming medical and psychological treatments. In some countries, conversion therapies are forbidden and may lead the clinician to prison. In 2022, Janine Desnoux developed a practice-oriented ethics support tool to assist care providers when dealing with moral challenges around decision-making competence in transgender adolescent care, which is a very important challenge. It's to assess this competence. The competence consultant tool is an interactive PDF containing 4 parts: clarify information, identity doubts and moral questions, guidance for conversations, and an overview and conclusions. In our view, the main ethical dilemma for us as child psychiatrists in the multidisciplinary transgender clinics is whether to adopt the affirming approach or the watchful waiting approach for children and adolescents. Regarding children, there are problematics around the reliability and validity of their consent. In addition, we need to consider the post-transition reported risks, including the psychiatric morbidity and the rating incidence of death transition. I would like to end this talk with our role as the EPA Standing Committee on Ethics. Should be to produce a position paper on the pre-transformation assessment of transgender children and adolescents, and recommendations based on the principle of autonomy, non-maleficence, benevolence, and justice. We suggest to include the following items, some of them based on the French-British academies. I would start with the definition of the child and adolescent and adult psychiatric role as consultant to the multidisciplinary medical team, which includes the psychiatrist, the endocrinologist, and the surgeon. Also, recommendation of assessment tools of the child or adolescent maturity for consent, which means with a full understanding of the transition stages and long-term consequences, such as infertility and psychiatric status. Tools like the semi-structured MACAT-T test has been recommended. Creation of a framework to work with the child or adolescent's parents based on the provision of empirical data of the pros and cons of the transition and on the psychiatrist's impartial position. Recommendation for therapeutic accompaniment after the transition and monitoring the child or adolescent's emotional status months along the transition process. Inclusion of appropriate clinical training in medical studies, promotion of clinical, biological, and ethical research pre and post sex reassignment intervention, provision by the school of appropriate staff training, and adoption of clear policies that support transgender children. Thank you for your attention.
Thank you very much, Sam, for your comprehensive and very interesting and informative overview, and pointing out also the ethical guidelines and the work of our Committee on Ethical Issues. Thank you so much. We will have a discussion after the next presentation. I'm now very happy to introduce our next speaker. It is Dr. Patricia van Wijngaarden-Cremers. She is from Netherlands, a senior consultant psychiatrist specialized in gender development disorders and addiction at Dimence, a large mental health facility in the Provence over Issel. Patricia was involved from the start in the countrywide networks for psychiatrists and other mental health professionals treating adults with ADHD, autism spectrum disorders, and addiction. As a trained psychotherapist, she is specialized in psychotherapy in adolescents and adults with complex, challenging behaviors. She is a senior research fellow with the Department of Developmental Psychiatry at Radboud University Medical Center in Nijmegen. Her PhD thesis, Gender, Comorbidity and Autism in 2015, was an eye-opener on the issues of gender-sensitive medicine and psychiatry. She has been active in the International Association for Women's Health over the past decade. In 2019, she started the Alliance for Gender and Mental Health, IAWMH, in Netherlands, of which she is the chair. The Alliance involves mental health professionals, users, family representatives, and organizations for gender equity and women's rights in the Netherlands. I'm happy now to introduce also the title of your presentations, Ensuring Care for Transgender Adolescents Who Need It, Response to Reconsidering Informed Consent from Trans-Identified Children, Adolescents, and Young Adults. The floor is yours, Patricia.
Thank you very much for the introduction. And I'm very glad I can speak about this topic with you. I will share my presentation now. So what are the topics I want to discuss with you? I want to show you how the paradigms are changing about transgender in the care in the Netherlands. I will give a historical overview, and I will have some clinical examples as well. And I will point out how this gender dysphoria is actually in autism spectrum disorder, because it differs from the general population. And I will discuss some causes, and also I will discuss some clinical practice and the dilemmas which I had by treating these patients. So from transgender to gender dysphoria, from the psychopathology to variants of gene expression. When we look at transgenderism, is of all ages, like my colleague Sam also pointed out. First, sexual assignment surgery is at the beginning of the 20th century. In 1975, we had an opening of the gender clinic in Amsterdam for security reasons. And in 1985, Professor Cohen-Ketten starts hormone therapy to put puberty on hold in toddlerhood onset genders. So then we started on to work to do something with young children and adolescents with transgender problems. In 2013, the DSM excludes transgender and opens a new category, gender dysphoria, for the gender identity confusion. And when we look now, what we have achieved at the moment, our Dutch Psychiatric Association last year made their apologies to the LGBTQI plus community, because we say it's not a disorder, it's not a problem, and we have to achieve that and not see it as something we can cure. So we made the Dutch association made their apologies to that communication, and here you see 5 transgender colleagues which were in the panel discussion, and they are all psychiatrists who are very known in our country and work on this topic as well. And they are an example for a lot of people and a lot of adolescents and children who suffer from transgender problems in the Netherlands. So when you look at, in general, at gender dysphoria, 4.6 and 100,000 are having gender dysphoria problems. At 2015, the prevalence was 1 to 3.8 for men, called trans women, and 1 to 5.2 for women, trans men. You see, there is a difference. There are more men in the general population who wants to turn into a woman than when you look at the ASD population, you see it's the other way around. So there is a difference. When you see at the children and adolescents who have gender dysphoria problem, it's 7.8. It's a high number, and in adults is it 5.5 of the ASD population. Oh, I'm sorry. When you look at another study, and they compared 5 data sets, it's a study of Warrior from 2023, and they looked at 5 data sets which had transgender, that all showed that there are more often transgender problems in the population of ASD than when you look at other psychiatric disorders. So somehow is there a difference between ASD and other psychiatric disorders? So other studies say that 15% of the females actually want to become a male, and 10% of the male wants to become a woman. And as I told you, it's the other way around than in gender population. In adolescent girls with ASD, it's even twice more than in boys. Another study from the winter here, they saw also an ambiguous about gender, especially in the women. In the women with ASD, it's 22%. And when you compare it to the males, it's 8%. So what about the Dutch protocol, how to cope with gender dysphoria? The Dutch protocol recommends to identify as soon as possible those young children who experience discomfort within the gender over a long period of time. As long as this discomfort worsens as they approach puberty, if it is a psychological stage remains stable, together with the family support, they are ready for the change. At the age of 16, they may start a hormone treatment, and at the age of 18, they can have the operation. But what about the children who have ASD? I told you when they have to be stable, it has to be stable, and I will discuss with you some problems about that. Let me first give you the example from Sophia, who always wanted to become Alexander, and which is actually a successful story. Sophia is the youngest of 2, and she has loving parents. As from 3 years old, Sophia always says she's Alex. She always wanted to be a boy. She goes to elementary school as Alex, and she's well accepted as a boy. She receives hormones to put her puberty on hold. At 19, at the age of 19, she gets a hysterectomy, a mastectomy, and receives male hormones. No gentle fear of complications. At the age of 24, sex reassignments were in her passport, actually. She married, she has 2 children, and she did it from she get it from the brother. And happy masculine man, happy married, a father of 2, and he is a successful lawyer. This is a successful story with not many complex problems. But it's, of course, it's not always as simple as this one. We have some other problems. As you see, and like also Sam said, as from the 80s to 2010, about 12 to 20 child referrals were zeg maar, referrals in a year. And it was doubled since, and mostly adults. But now we see a kind of epidemic of gender dysphoria in adolescents. And mostly with comorbidity as autism. We see a lot of, especially girls with autism, who are referred to those clinics. Let me tell you about a study I've done in our center, in a patient clinic, a cohort of 16 adolescents who were inpatient at that time, 11 girls and 5 boys, all with ASD in the age between 14 to 20 years. 4 out of the 11 girls had concerns about their gender identity. And 2 of them had actually gender dysphoria, because you can have also concerns about your identity, and that's not the same as gender dysphoria, of course. So but none of the boys had that same concerns. So somehow the girls have more concerns in general when they have ASD about their gender identity. So it's a common thing in adolescents with ASD. And we have no good explanation for that. One of the things where we have do much more research on is the higher levels of testosterone, because we know at the population of ASD in general, you see higher levels of testosterone in ASD girls compared to girls with no ASD. One also say that the not being confident with their gender is because they feel different. And when you think autistically, you say, when I'm not feeling like a girl, so I must be a boy. Very autistic thinking. Maybe it's that playing a role that they are confused about their gender. It can also be a part of a broader identity question, because you're also in an age that you don't know who I am. You have a lot of questions. And nowadays, when you look at the internet, and you have to know everything, and you have to be sure, and you must directly say what you are, who you are, etc. And a lot of young boys and girls are not able to do that at a certain age. It's also the black and white thinking. When I'm not this, I am that. And they don't see the gray between it. And there is an interaction between body dysphoria and sensory sensitivities, because change is difficult for people with autism. And when girls get breasts and they get their period, there's a lot of change, and that can also lead to a lot of confusion, and also questions about their gender identity, because I don't want to change, so I have to be a man and not a girl. And of course, it's something different than a real gender dysphoria, being transsexual. And you have to separate that. You have to look into that. What is exactly the problem? Because only a few amount of all these people with gender confusion have actually gender dysphoria. So let me go to some examples in my practice where it is a little bit complicated and we have to deal with we say in the Netherlands when you can have actually the gender transformation. Let me go to the story of Samantha. She's 16 years old and she has a lot of self-harm. She did several suicide attempts. She's bullied when she was young and still is bullied. She has a PTSD because of the bullying, and she is age 14 and she had already had several treatments, and she is diagnosed with ESD. And when you look at the story of Samantha, she looks like a boy, she wants to be a boy, she dresses like a boy, she already changed before she entered our department in a boy's name. She wants to be referred to the gender clinic. And when you look at the history and you do the good counseling and you talk to them and all the stages Sam already talked about, she really wanted to become a boy. But the problem was, the mother agrees, but the father not. And then you have the problem, what do you do? And we can discuss it maybe later. What we did is talked with both parents, and the parents were separated. So we had to talk separately because together that was no issue. And we talked with the girl who wants to have with Samantha and her father, and let her explain to the father with some help on why it's so important for her to change and what she directly feels, and to help the father also understand what it means for her. And so we took some time, but initially he agreed and she could go to the process, and it was really a success, fortunately. But sometimes you don't exceed and you cannot go on with procedure because of the rules we have in the Netherlands. So in the end, this is a story was really well ended. Like I said, the Dutch protocol, here you have it again. You need the family support, but also the psychological status has to remain stable. Now let's go to an example where that is not the case. This is a story of Melanie. She's 20 years old. She's known with conversion from the age of 13. She also developed at the beginning of her puberty eating disorders. She's known with self-harm, a lot of suicide attempts, also some severe ones. She's sexually abused when she was young and had a PTSD, which is treated well in the end. She was, after the age of 14, she had several hospital admissions and treatments, and she had late diagnosis of ASD. When you see the story of Melanie, she hated her life, and especially she hated her body. And because she hated her body, because she didn't want to be a woman, because she felt like a boy. She always did and always wanted to be a boy, and she wanted to be like a brother and do the things like a brother did because she felt more like a boy. And because of that hating of her body, that was the beginning of the eating problems, because when you are slim, you don't have breasts or less breasts. And that's why she had breastbone, but she wanted to have no female figure. She wanted to be as flat as possible. So what we did, what we did, we had a huge problem because she still did a lot of suicidal attempts because she didn't want to be a woman. And that's why I agreed and helped her to refer her to the clinic, because her parents agreed to it, because they know she wanted always to be a boy. And I could convince the committee to do the operation and the process for her. And I know it was a huge dilemma because she wasn't stable. That's true, she wasn't. But the cause of instability was actually the transsexual problem. So we took the risk after a good talking with all the people and also the whole committee, and we discussed it, and we did the operation. And I must say, in the end, of course, her problems are not over. Let me be very honest with that. But the severe suicide attempts are gone. And also, the conversion is gone. And she is more treatable now than she was before. So that's one of the dilemmas you sometimes have as a clinician. And that's what I wanted to share with you. And I won't do this again. I agree with already Sam pointed out so clearly. We need, as the WPA, to have a position paper. We really, really need it, and we need some tools how to do things. And we do it not only by country, but I think we have to do this worldwide. And I really think we have all have to agree on this, because it's very, very important. And I think we need a appropriate clinical screening in medical studies, so we know how to deal with the thing. We have motion of clinical, biological, and ethical research, pre and post and reassignment interventions. We need much, much more research than we have now. And we also need a recommendation to the Ministry of Education to allocate appropriate staff training and adoption of clear policies that support transgender children. Thank you very much.
Thank you very much, Patricia, for this very interesting talk, bringing us a little bit closer to your daily work and to the Dutch protocol and your recommendations. You know that the Committee on Ethical Issues of the European Psychiatric Association is working on this topic, and we have also, we are on the way to prepare a position statement and so on, just to inform you. And Sam is also a member of our committee, and he has a lot of very good inputs to this work. So thank you very much. We have less time. I would like to give the possibility to get back. Maybe we can leave the share position of your slides. Patricia, could you?
Yeah,
Thank you very much. We have received a lot of questions. I would like to give the floor for the first question from Koray Bashar. He is a member of the section on transgender of the European Psychiatric Association in the board of this section. He has many questions. We cannot address all of these questions, but maybe one of these questions, he wrote that research from different centers with high number of referrals compared the clinical and dysphoria-related features of referrals in different time intervals. They failed to show a difference in the population. So isn't it more likely that we have an increased presentation on the clinical rather than increasing gender concern underlying this change? Maybe very short answer, because we have a lot of other questions. Who would like to?
Yes, I think that I agree with you. I think we have really, but I think we have much more than one reason for this increasing number. It's not just one reason. Of course, the transgender didn't start for the 10 years ago. It didn't start. Of course, it existed before. And of course, there were other treatments and no enough understanding how to approach it, how to understand it, how to treat it. And now we have new technologies and we have new tools in order to assess it and to understand it. But at the same time, I must emphasize the role of the media. You cannot ignore it. I think we have a multifactorial response. We have much more than just one factor. It's a multifactorial approach. And I think that we should also participate in the media. We should participate in the media and explain that it's not just the TikTok and the telegrams and things like that of adolescents, which are enough to explain the phenomenon. We have to explain what are the risk and protective factors of this phenomenon. It is a social phenomenon anyhow. Society has changed its values anyhow. But I think we should give a lot of attention to the media, participate in the discussion in the media, and approach adolescents, and even try to see how to have an input in the education system.
Okay, thanks so much. I'm going on with another question in the introduction. I underlined the question, what is the psychiatrist's role in this topic? So would you like to answer, or Patricia, what is the role of the psychiatrist?
I think we have a very important role where that the child really understands what the meaning of it is, and if it's really dysphoria and what it means to them. And that's a very important role, that he understands everything what's attached to that subject, that he really understands what it means. And we have a very important role in that, and not only for the child, also for the parents, and we have to guide them when they're going through the transition. We also have to stand by them and get them through that period. It is not only so you know that now and success and you had the operation. No, it's a total process, because we know also afterwards they need a lot of understanding and work you have to do. So it's a very important role as a psychiatrist, but you have to know how to do it, and that's why we need the tools, and we have to talk about it with each other much more.
And I would like to add to this that one of the roles that you have emphasized, which is the assessment.
Yes.
It's very important to make the assessment, because this is the the psychiatrist should be the first person to see the child or adolescent.
Yes, of course.
Because and to assess. It might be also one of his, I don't know, psychotic symptoms. Yes. It might be psychopathology. It might be. Of course. And to understand the second point, which is very important, not only psychopathology, but also to see if the consent is based on emotional and cognitive factors, which are in relation to the biological age. This is very important, because to give a consent, you have to appreciate the weight of this consent in the treatment.
Yes, I totally agree. Yeah.
Thanks so much. Another question to both of you. Here's one question. What to do if the doctor's decision on treatment differs from the parents? It was a question forwarded during the registration time of the webinar.
Well, I think Dr. Wijngaarden has a lot of experience with sitting with parents. And when she said in the cases she described, we convinced the father to agree, this, I think, is the main role in the disagreement, because if there is agreement, no problem. If there is a disagreement, then I would say we have two different approaches. One is for children and one is for adolescents.
Yes.
The one for children, we sit with the parents and the child, and then we open the data and explain to them, what does it mean, this process of transition? With the adolescent, I usually start with the adolescent alone.
Yeah.
Start to get a confidence from him alone in few sessions. So, because otherwise, of course, he identifies me immediately with the parents. And so he start, and that's why I think our role, there is not an agreement between them. As I said, first, children, we sit together. And as I said before, very important, because that's why I'm sorry, but I gave all these statistics, because we have to give it to them to explain what does it mean, all the attempted suicide. That's why I called it risk factors. Yes. But at the same time, it's very important to emphasize, because we have also protective factors. And the protective factors is really the quality of life of these children or adolescents. How can we improve the quality of life by their decision to collaborate? The risk and the protective. That's the role, in fact, in cases of non-agreement between children and parents.
Okay, thanks so much. Another question, who is the key person in obtaining informed consent, considering that the patient is a minor? Parents?
Of course.
Yes, of course, but this is an important...
Of course.
Yes.
Yes.
Always parents.
Yes.
Up to the age of 18.
Yes.
Up to the age of 18.
Yes.
Then it's just to the patient.
Yes. Another question is, what treatment approach should be considered in the approach of an adolescent with doubts about his or her gender orientation? It's an adolescent with doubts about his or her gender orientation.
You have to talk what is really the problem and just explore it, and what is really the case. Is it really a gender dysphoria, or is it something else, or just a general identity problem, or a general identity thing? So you have to talk with the child how it is. And like we talk about a lot of things, and I think we need more practice about how to talk with a child about this. And I think when I looked at my education, there was no room for that. I never heard of something like that. I had to teach myself. But now I teach, of course, the young doctors about it. And I think we need that much, much more. So how do you talk about it? And before, it was a topic also a lot of clinicians didn't want to talk about it. They try to go around it.
Thank you very much. We have now to finalize our webinar because time is over. We have only 1 minute. I'm very surprised with time runs very quickly. I would like to thank you both very much for your very interesting and impressive talks. There are a lot of other questions which we couldn't address now. I'm sorry for it, but the time was or is limited. Thank you very much for your participation. Thank you very much joining or attending to our webinar. And we are on the way to work, or we are in the process to work with within our committee, but also in cooperation with the section on transgender to prepare a position statement of the EPA. And we are also on the way to organize other events like this webinar. Again, this webinar has been recorded and you can watch it using our website, the link on at our website. And if you have questions or comments, you can get back to us later on. Thank you very much. And thank you also very much to the EPA giving us this floor. Thank you very much for the technical support. And I hope we will meet in another time to discuss this topic or going on to discuss it. Thanks again and have a nice day.
Thank you
Thank you.
for chairing this session.